Thank you. You opened my secret to peace. I would like to invite my panelists, Dr. Bhavin Shah, Senior Consultant at HOC Vedanta, Dr. Shilpa Gupta, uh, Dr. at PD Hinduja, Dr. Abha Dubey at Ahmedabad, and Dr. Sujay from Rajkot. So we have a short time, so I would request the panelists to be very brief in their answers. We have a first 45-year-old working professional with diagnosis of CML, treated with imatinib, and then changed to dasatinib for suboptimal response at 1 year. And in about 6 months, he is having difficulty tolerating dasatinib with effusions and diarrhea. So, what could be the reasons for treatment failure? Quickly, anyone? Any panelist, please.
So, sir, treatment failure can be divided into two types, whether it is due to intolerance or it is due to resistance. So, these are the two main ways we find a treatment failure in CML. And more commonly that we see is intolerance as compared to resistance.
Right. So, an important point in this slide is that the failure rates with successive TKI treatments is high. So, if the first time is 30%, then second line 50%, and using a second TKI, which is also second generation, the results are very poor. And so far we did not have anything, so obviously we kept doing it. But this is very important to realize that the failure rates on the third line are extremely high. And I think if anyone can talk about the importance of early molecular response in predicting the failure, any of the panelists.
Like it has shown that those patients who are attaining like EMR that is less than 10% of BCR-ABL like at 3 months or like 6 months, they have like slightly better like long-term responses like which is attaining MMR or like DMR like with so I think it stands with any TKI like whichever helps to attain early EMR that translates to better like long-term survival or less chances of relapses we can say.
So do you change the TKI in your practice if the milestones are not met, or you wait for kind of a frank major change in the BCR-ABL?
So sir, like usually like at 3 months I don't change like mostly like nowadays it is said that we should be a little bit more conservative, so like at least till 6 months I wait. I usually use only like a second generation TKI as a first line TKI, so that's not a problem mostly with the like if you use low dose dasatinib as a first line TKI. So most of the times like EMR is attained at the 3 months. Only in like 1 or 2 cases I have seen that it is like difficult to attain. But the imatinib if you are using, then maybe we can be a little bit more conservative. Or I feel that if you are using in old age, then in that cases also we should be a little bit like slow to like shift to the different TKs.
Right. I think the age, so overall treatment goals also matter. Yes.
Yeah, exactly. So what is the intention of treatment? If you are looking for TFR, then the milestone is little more important. In elderly patients, if they are tolerating treatment well, if they are doing reasonably good and they are maintaining that molecular response, I think we can continue with the same.
This is a very important point. This is where seniority matters. When you listen to a senior, he would have gone through these issues of switching too frequently and jumping at reports. So over the time, even imatinib can achieve more and more deeper responses. And so if TFR is not the goal, then no need to push.
So I do tend to increase the dose of imatinib. I mean, if I don't have early molecular response at 3 months, won't switch the TKI, but probably increase the dose to 6.
One other way to manage. Any opinion?
Yeah, so one more point which comes to me is when I'm looking at the quantitative PCR, I just don't base my decisions on one value. If the value has been only around difference of 0.01 or 0.1%, then I wait for the next 3-month monitoring and then take my decision
Right.
based on that.
And we are assuming that the lab is good. Okay, so this is also an issue that many times patient would get their test done somewhere. So don't depend just on that. The one which you are used to, the lab quality is also very important. And the point I stressed earlier, also the compliance. Any issue with not achieving milestones, make sure that the compliance is good. Please ask repeatedly that whether they are taking the drug regularly. In general, patients will not tell you this because they don't like to, get scolded by the doctor, okay? Or don't want to offend the doctor that by saying that we are not taking the drug. But a good number of patients would be saying that because of the gastritis, because of other issues, they are not taking, they skip, there were issues, they could not come on time, and so they were 1 month late, 2 weeks late. There are many such issues. So compliance is very, very important. Otherwise, you will end up just cycling the drug too frequently, and then after 2-3 lines, you will have nothing left.
The drug interaction is another concern, always drug interactions. So patients are
Another one, yeah.
treated with some febrile illness, with some macrolides, and that also makes the bioavailability of the drug hampered.
Plus, even that time again, they may stop the drug. That, oh, I was sick, I was having too many drugs to take, so I stopped the imatinib for 7 days. So you have to ask repeatedly and advise them that this is very, very critical, because since the patient is not sick overall from CML, they forget the importance of compliance. So we have to keep reminding them, not just initial session, but after multiple times. With my very standard tagline for them is that if you forget to eat food, it is okay. If you are so busy that I forgot eating my food, then I am okay with that. But you should not forget the drug. So treatment cycling, I think we have discussed that it leads to whether resistance or intolerance. But if you keep switching the drug, then the overall outcome is much worse. As you can see here again, at 8-year overall survival with more than 3 lines is 4 times less, so which is a much poorer survival compared to continuing with the first line. So compliance is very critical. Now, and the TKI cycling can lead to resistant mutations, including the T315I, and thereafter the outcome is much worse, as we all know. So, can side effects due to the treatment impact outcomes in CML patients? So, we understand the quality of life part, but whether it will impact the overall survival.
Absolutely, sir, because side effects might lead to drug discontinuation. So that can lead to resistance to the drug and not achieving optimal responses. So absolutely, yes.
So here if you see that the TKI intolerance in these pivotal trials remains a primary reason for treatment discontinuation. So in the IRIS trial at 5 years, 4%, and in the second generation TKIs, it is about 12 to even up to 25%. So this is intolerance is the bigger reason for discontinuing the drug. And this is where I think the counseling matters, that why this is important. I believe that our discontinuation rate has been probably less because in India we have been pushing patients since there were not much options. So when you see the international data versus I think our patients keep taking because we know that the second options are very expensive.
And the patients who are on GPAP support program,
Exactly.
they are always in a fear of if they are
Yeah.
not taking regularly, the
Right.
treatment might be discontinued for them.
Exactly. Yeah, I think so. It is important. In a way, I think this signifies the value of compliance again. And the GPAP patients have been doing so well. I think a large majority are doing well. And there also, I've seen those who are non-compliant had significant issues of loss of PCR. But the ones who are compliant have generally done very well. So, intolerance resulting in intentional non-adherence can reduce the outcome. And as you can see here, that if the adherence was more than 90% versus less than 90%, the outcomes are so different that 93% versus 13% MMR, 76 versus 4% MR4, and CMR, or what we now call DMR, deep molecular response, 43 versus 0, with just adherence less than 90%. So, not taking imatinib just 2-3 times a month itself is a very, very important predictor for failure. And this we need to highlight to our patients repeatedly at every visit, more so when they get good response, because then they may just relax that now if I am going to a marriage function or somewhere and if I miss, it is okay now because I already have achieved a zero disease in the body. So they're even more important. So how does asciminib differ from the traditional TKIs used in CML treatment?
So asciminib, like in terms of mechanism of action, also it has like different site of like attachment on the BCR-ABL molecule. So it attaches on the like myristoyl pocket as compared to the traditional TKI, which attaches on the like ATP binding site. Then in terms of so this is in terms of like mechanism of action. Then another is in terms of like activity. The trial like which is compared with the bosutinib like has shown like the side effects are like slightly lesser than the bosutinib overall they have shown. Like although the comparator is not an ideal comparator to check with.
Well, at that time, there was no other option.
Yeah,
so
right, sir.
when the trial was initiated, even now, I think after failure of two, second generation TKIs, we have nothing else. We still have bosutinib if patient cannot, take asciminib. So it was a fair comparison. And they used the right dose also, 500 milligram. Otherwise, you would have complained that the dose was lower. That's why the efficacy seemed better for asciminib. Okay, so what is the evidence with asciminib impacting outcomes? Anyone? The assembled trial data. You know that the what we just discussed, the asciminib 40 milligram twice daily, or it can be also taken as 80 milligram once a day, compared to bosutinib in this third line data with 3.7 years of follow-up. Anyone would like to comment?
So the patients who had relapsed or a progress on the two line of treatment, they were treated in this assembled study. And here also they use a second generation TKI, which is compared to asciminib, which has a different mechanism of action and different binding site for the molecule. So now, despite of using in a two-line failure, these patients are showing good molecular response. Even the deeper molecular response are achieved, though many of them they are in a delayed phase. And the better part is that the patients who have achieved the major molecular response, they are able to maintain that compared to second generation TKI. Right. So and the other advantage is that after ponatinib, the another molecule which has shown some advantage over T315I.
Right. I think that's also a very important point, that ponatinib is not available in India, and whether we get it somehow, also the risk of managing ponatinib is significant. So this is again what Dr. Bhavin has explained, that the BCR-ABL rates at week 24, 96 and 156 are clearly better with asciminib. The MR4 and MR4.5 rates also at all these different time points continued to be higher. So even in the third line, there is a 20% about MR4 and 10% MR4.5. The PFS and overall survival as of today remain equal at 5 years with asciminib and bosutinib. The same thing what we are seeing with imatinib versus second generation TKI. So what is the safety profile and quality of life impact with asciminib?
So with regard to the like safety profile, so that is I think like one of the most important part, like which leads to improved compliance also, as well as like you can say efficacy. So like back in 2020 we had the compassionate access program when I was working in RGCI Delhi. So that time like I got like I used to apply for the asciminib. So like we got a lot of patients started on that. So I saw that the like almost all the patients, they have like hardly any side effect. So we didn't see like many side effects leading to the discontinuation specifically. And we had also used in many post-transplant patients as well that time, in CML blastocysts post-transplant patient, because the patients are not affordable for ponatinib and we were getting free asciminib. So then we saw that it is like very, very tolerable. So that was the first thing which I saw about asciminib. Then like when it was launched subsequently like last year, so I think the side effect profile is like distinctly different from the other TKIs. Like after the asciminib, like after the launch of this imatinib, lot of TKI came, second generation TKI, but like almost all the TKI have some or other side effect, like nilotinib, bosutinib or dasatinib. So we always explain to patient that you may have some side effect. But when I see asciminib like through the like in the same line, so I don't feel scared of like serious side effects which can lead to discontinuations. So if you leave the I think cost or finances aside, the safety profile is it's better. They have shown in the studies when they have used like specifically high dose, so it may lead to like vaso-occlusive events like ponatinib, but I think that is in the long run. I have like not much experience of those like adverse effect profile, but they have shown that it may lead to such side effects.
So I think overall, as we've seen in the larger studies also, that the tolerability is better. And that is why the better ability to maintain the drug. The most frequently reported side effects were thrombocytopenia and neutropenia, which we are generally used to as hematologist oncologists. And it is good to listen to the personal experience of the panelist about the asciminib, at least in the short term. Dr. Bhavin?
I have not used that molecule, but then what I found that after imatinib, it is the first drug in which we can have a more acceptability in because if you use a dasatinib or a nilotinib, there are a few patients where it is absolutely contraindicated. Whereas in imatinib, you don't find anything which is directly contraindicated. Same with asciminib, I think, except pancreatitis, the patient who have previous history of pancreatitis,
Yes.
they are
So
this
very
drug
small
can be,
subset.
Yeah,
That is
exactly.
good. Yes, it's a good point. Yes, sir.
To add to this, we have given asciminib to a handful of patients and very user friendly. We even used it as off-label post-transplant in BC, and we had CML in BC. We have found it's very manageable if you use in the right doses, number one. Number two, one of our patients had diabetes and also renal dysfunction. In that, there is a problem. Besides the upfront pancreatitis as a side effect, it can increase your creat if you are not careful with the dosing. And so thrombocytopenia and neutropenia can be dose limiting, but definitely creat can worsen. Otherwise, very user friendly, and like you all said, I want to just reaffirm that we found it was very acceptable and user friendly with minimal side effects as compared to the other TKIs. Thank you.
Regarding the dosing, I think a very important point that we are used to for all TKIs a standard dosing. But the good part is that not all patients need the same standard dose. So if they are not tolerating but they are getting PCR control, then it is okay to continue at lower dose and don't worry about switching. And this you would have seen with imatinib, that even at 300 milligram, sometimes 200 milligram, people are maintaining PCR. And same, I had a communication with one of the faculty international for my patient on asciminib with T315I, and he said that don't worry about giving the 5 tablets BD. If you cannot manage, you work with the lower dose, just closely monitor PCR, and if it is maintained, you are okay. This is the study dose, but you don't have to necessarily push. So this is one important point for all TKIs. And even with T315I, this was the advice given to me.
Can we start at a lower dose and then go up, or start at a higher dose and then
I
come?
think you should start with the standard dose, because ultimately, in theory, with lower dose, you can have a higher chance of resistance. Now, for those patients where you just can't manage, it is okay to come down. That's the message. And the quality of life data in this study also favored the practically for all aspects, it was favoring asciminib. So I think that was the last slide. So in terms of the efficacy as well as the safety and the health related quality of life measured by the standard parameters, also asciminib fares very good. Thank you.